Knee replacements have come a very long way in knee surgeries. 40% of the people over the age of 40 have some form of arthritis. I see people regularly even in their 30s with arthritic knees. No matter how well done, every knee replacement has a lifespan. If you take the case of a car tire, if there's a puncture, you can replace it.
You just fix the puncture.
Absolutely. Pretty much the same way. If a young patient has a cartilage defect, we can repair it. If you have chondromalacia patella and you're young, we can use your own blood, concentrate it to about 12 times what is called as a highly concentrated form of platelets, and then inject it back into your knee. People who have got early arthritis, so many options exist.
Hi, hello everyone. Myself, Dr. Mona, and I welcome you all to My Talk with Mona. So, earlier, quite some time back, let's say around 25 years back, it was all about long, lengthy cuts, long recovery period, painful procedures, and heart full of fear, whatnot. But now, it's all about tiny cuts, limited procedure time, and then quick recoveries, whatnot. So, wondering about what am I talking? Yeah, it's nothing about the advanced knee replacement surgeries and the advancements in orthopedic surgeries. So, today we have Dr. Aditya Kapoor, the Director of Orthopaedics, Omega Hospitals, Gachipoli, on a Mad Talk with Mona to give us more insights about the recent advancements in knee replacement surgeries. Hi, Dr. Aditya Kapoor. First of all, thank you so much for your precious time on my Med Talk with Mona. Myself, Dr. Mona.
Thank you so much, Dr. Mona. Thank you for being here. And it's a great pleasure to be here with you this afternoon.
Likewise, sir. So, doctor, for a while, I would want to go back in time, let's say 10 or 20 years back. Considering orthopedic surgeries, precisely knee surgeries, 20 years ago, and the current knee surgeries, like your views and your insights on it?
I think knee replacements have come a very long way in knee surgeries compared to what we used to do 20 years ago. Surgeries today are a completely different aspect, not only in the way we do it, but technologically. Now, what's remarkably and very interesting is that knee replacement today is one of the most common surgeries and perhaps one of the most successful surgeries, if I put it, in the history of mankind. And if you look at the disease burden on our people in India, it's interesting. 40% of the people over the age of 40 have some form of arthritis, and almost most over the age of 60. And those who are very symptomatic, naturally, they end up with people have knee replacements as a final solution. Very successful. And the last 20 years, I've seen it evolve. I remember 20 years ago when we used to do knee replacements, we used to see that fear, and people would say, oh, my knee is going to hurt. Am I going to be in hospital for a long time? And certainly we used to see that. Both in the UK and in India, we used to see that people were admitted for longer. And perhaps pain control measures were not as sophisticated as today. Also, people used to perform traditional cuts, what called as the incision. The implant itself has changed so much, the prosthesis that we put inside the knee. So things have evolved in numerous ways. One, with the way we plan the surgery. So earlier, people would expect to stay, but now people go home in a day or two.
That's real quick.
It has changed. It is remarkably transformed. People expected to have large cuts. Today, people have small incisions.
Minimally invasive procedures, if I'm not
wrong. We don't cut the muscle. Most of my knee replacements, they have a muscle sparing approach.
Oh.
And I've seen when we started doing knees traditionally, we used to all cut the muscle, what's called as the medial parapatellar. Today, in India, a lot of the surgeons, if not most, will involve a muscle sparing approach. We've been doing this for some time. Additionally, when you combine it with, so we have a program called as accelerated knee recovery, which we have been doing for well over a decade, if not more. And people, we plan. So we identify the patient if they are fit, if their muscles are good, and if the arthritis is not very, very bad. Because if it's very, very painful and the knee is extremely bad, then they take a bit longer to recover. But 90% of our patients, those who come to us in time, when you operate, they walk in 6 hours. And if you plan a unicompartmental knee, you can even send them home. So we also have a daycare. You can send them home in a day if they have the facilities of monitoring at home or they live close to the hospital. Especially true when you replace half the knee, called as a partial knee.
So, irrespective of complete knee replacement,
Yes.
there are possibilities. I mean, like the partial knee replacements are possible.
Oh yeah. So like you have 4 tires in a car, and if one tire is spoiled, then you wouldn't want to replace all 4. Similarly, you have multiple compartments in a knee. You have the inside called as a medial, you have the outside called as a lateral, and you have the one behind the kneecap called as the patellofemoral. And in most people all over the world, it is the inside, the medial compartment that wears down. So for these people, we perform a unicompartmental or partial knee replacement. And in that, the advantage is you are preserving the normal compartments, so the ligaments, the other parts of the knee. So it's a small incision, virtually no disruption of muscles. You replace only that bit, and they are so much more functionally active than a total knee replacement. You find that they can bend their knee well, they can be more active, and it feels more normal, especially when you come down the stairs or you carry out those activities. You can even play activities like doubles tennis. You can have some impact activities. So unicompartmental knees done well are very rewarding and satisfying, but you have to choose the right patient.
Considering all this, as per my knowledge, earlier I was like, I can say most of the grandparents or beyond them, like great grandparents, were going through this knee issues and all. But in this current generation, I get to see many youngsters are down with this knee pains and joint pains. So, your views on it? What could be the reason behind this?
So that's a fantastic question, Doctor. You see, this is something that concerns us, and we call it the young arthritic knee. And we are seeing people, or I see people regularly, even in their 30s, with arthritic knees. And you don't want to be replacing those knees. Yes, some young people may end up with a replacement, but those are people who have inflammatory arthropathies, like for example rheumatoids. In them, you are forced to do a knee replacement if it's very, very bad and they're young. But for most other people, you wouldn't want to replace knees in a young person. No matter how well done, every knee replacement has a lifespan. And if you operate on somebody who's in the 30s, 40s, perhaps early 50s, inevitably they're going to end up with a revision. So these young people concern us, but there is hope. And as science evolves, we are able to deal with them, and I like dealing with the young arthritic knee. So if you take the case of a car tire, if there's a puncture, you can replace it.
You just fix the puncture.
Absolutely. Pretty much the same way. If a young patient has a cartilage defect, we can repair it.
Okay.
If, like your car tire, that is not aligned and it's bent, it will wear out on one side. Pretty much the same way, if your knee is bent, what is commonly called as a varus deformity, or rarely bent on the outside valgus, in young patients we can straighten the knee, where we have a special X-ray called as a scanogram. We see the alignment of the knee and then either carry out a high tibial osteotomy or a distal femoral osteotomy for valgus, and you can correct the alignment. This can be combined with cartilage restorative procedures as well, and very often these patients may have a tear in the shock absorber called as the meniscus, which we also deal with through keyhole surgery at the same time. So when you see these people, these are small incisions. When you operate on them, straighten it and fix it, then it not only buys them time, it delays the surgery and may avoid it altogether. and these people get to keep their own normal knee. There is another condition called as chondromalacia, and especially behind the kneecap, people come with pain in the front, what's called as anterior knee pain. And very often they will complain that when we are sitting for long periods, we get pain behind the kneecap. It's typically called the cinema sign. And if you have chondromalacia patella and you're young, we can use your own blood, concentrate it to about 12 times what is called as a highly concentrated form of platelets, and then inject it back into your knee. And we have had a terrific experience with patients, young patients. Slightly older patients, we then use pooled mesenchymal cells from donors and then inject them back. So people who have got early arthritis, so many options exist. Very easily, you could give supplements, you can give what we call nutraceuticals, you can give an injection of hyaluronic acid in older people, perhaps combined with pooled mesenchymal cells, and for younger people, combine corrective osteotomies if necessary along with cell therapy. And we find that we are able to deal with a lot of people earlier.
So it sounds like there are handful treatment procedures which are absolutely non-surgical. It's happy to know.
I think most are. I mean, if you find people early, if people seek help at the right time, uh, a replacement is always the final ultimate solution for people in whom you have severe arthritis and in those where nothing else is possible. But for most of our patients, and for this you have to have good accurate diagnosis, which is where having scanograms, good MRIs, all this comes into the picture.
Concerning these young individuals, apart from all the possible non-surgical treatment options and everything, are there any genetic factors or hereditary factors playing a key role for them to be operated at a young, early age?
So there is unequivocal evidence that genetic factors do play a part, which is where you find that people, for example, in the case of inflammatory arthropathies like either rheumatoid or ankylosing, you find that people have factors in their blood that make them more prone. That's why rheumatoid, ankylosing, and all these arthropathies start young. But what's interesting to note is that just because you have a rheumatoid factor in the blood doesn't mean that you have the arthritis. It's always a trigger that stimulates it. Similarly, you may have, so for example, you take ladies. Ladies are more prone to arthritis. And in that case, it's not just genetical, it's also to do with the way that weight falls on your knee. Obesity, as you know, increases the force on the knee by about 4 times your body weight. Similarly, women have broader pelvises, so they have a tendency to put more weight on the inside of the knee. Additionally, most of our people in India tend to have, compared to the Caucasian population, slightly bent knees called tibia vara. When you combine that with our habits, in our culture, it is important that we all, squat, we sit cross-legged, we kneel. So these things do tend to put a little bit more force on the knee. So it is a multifactorial. And these days, as you know, there is a lot of vitamin D deficiency as well. So when you combine, absolutely. I mean, most of us, including me, have been vitamin D deficient. 25 years back, it was hardly recognized. But today, there has been so much of awareness, fortunately, and most of our people recognize, especially after COVID, the importance of vitamin D.
True.
So, if you combine factors that are related to genetics, you combine factors that are related to the patient's own anatomy, as well as social, you can understand why we are all facing an epidemic of arthritis.
So, how about concerning the daily routines and activities, the dietary factors, or additional add-on habits? How all these contribute to this arthritis?
So that's a great question. I think, as with most things, the foundations are laid young and early. So I think one of the really, really important things is that at all age groups, we must remain active. If you're not active, then the cartilage is not exposed to stress and it breaks down. So, much like if you're overactive, then if you're underactive, it's bad as well. So, at all age groups, keeping your muscles strong will put less load on the joint. It will not load abnormality. Similarly, if your weight is low, so like we were discussing, weight has an enormous bearing on the forces on the knee. Each kilogram translates to 4 times more weight on the knee. So you can imagine how important keeping your weight down is. Um, Vitamin D. Vitamin D is important. Vitamin D also helps in strengthening the cartilage. Activities and food. So, if you're going to do any activities, it's important that you warm up, you cool down, keep your muscles strong. Because if your muscles are not strong, it will put abnormal stresses even when you're carrying on the activity. Similarly, if you don't warm up and cool down, you may tear some ligaments in the knee, which can later lead to arthritis. Food is extremely important, and I think this is where traditionally a lot of Indian food that is home cooked and has been healthy has always been appreciated. But as with modern lifestyle, a lot of processed food is being used,
Yeah.
packaged foods, and these have, besides low nutritional value, they also add weight. The processed food can lead to stresses on your cells and body, and these can help in or retard cartilage restoration naturally. And I think it's a huge problem, especially with children. I'm not saying that there should be abstinence, but I think there should be enormous amount of control with sugary food, colas, pizzas,
Which
burgers,
has yeah, that has become really quite a tough task on young
especially
parents
with children.
because the commercials are so attractive that it's like bearing with the. It feels like rather than raising a kid, it's like dealing with a tantrum 24/7.
No, I think, it's not just kids. We are facing this even with older people. It's not
Yeah,
just
true.
the question of the, yeah, I do agree that, advertisement should carry warnings and should be a little more socially responsible.
True.
Additionally, it's also the pace of modern life.
Yeah,
Sometimes
the
you,
hurry-burry lifestyle.
absolutely. So you find it easier to just grab a sandwich
Yeah,
or a
true.
burger rather than spending time eating food. It's important to chew your food. It's important to have a healthy, well balanced diet
Grab a
because
protein shake, then rush to work.
grab a
Sorted.
burger, grab a pizza, grab a bagel, run to work. Yeah, I completely agree with you. And we're all guilty, but we've got
Yeah,
to change.
honestly.
Yeah, we've all got to
And
change.
there are like barely a very few people who keep a check over their complete balanced diet routine or exercise or a disciplined lifestyle, I can say.
I agree with you, but I think this is where we all need to step in, not just in terms of the individual,
Yeah.
but right from the government to right to your physical trainers to people who will also help you identify. Prevention is better than cure.
True.
So I think there has to be all these changes coming at the level of society. So people are not aware. You need to increase awareness. There is a social responsibility, and this is something that should also be taken up by the corporates.
But I believe that awareness plays a key role considering all these factors because when a child, after coming back from the school, if he complains of constant leg pain or hand pain or any other sort of pain involving the bones, the mother starts complaining like you must have played for too long or you did this, you did that, and but not just the mother, anyone in the family, they may not.
So I agree with you. I mean, when we were growing up, if we had pain, people said these are growing pains.
Yeah.
Nobody recognized that this is vitamin D deficiency. And for years and years, people used to give calcium.
Yeah.
Similarly, nobody realized that it could be in older people. When you're coming back and you've done a lot of activity, sometimes people may consume a lot of protein. The protein shake you were mentoring.
Yeah.
So if you consume a lot of protein, your uric acid can go up.
True.
So there are a lot of things that come into the picture, and that's exactly why a good, healthy, balanced diet, along with timely checkups.
Yeah, that's why I was mentioning the commercials and self-interpretation or misdiagnosis, self-diagnosis using ChatGPT or whatever it is. The parents come down to a conclusion that okay, the child must be going through some deficiencies, and looking at the commercials, they'll just like dump all that
That's
supplements into the kid's
that's a
tummy.
wonderful thing you just brought up. Chat GPT and AI.
Yeah,
It's still artificial. And what it does is it picks up on anything that you type in. So if you could type in pain in your thigh bone, it can tell you it is something simple from vitamin D deficiency right up to cancer.
true.
Because it pulls in all the data. And that's where prevention or screening through the community level and your primary care physician is important.
Uh, as far as I remember, when I was a kid, until my 10th grade, I can say, there were timely pediatric checkups. I mean, like my parents were regular with my checkup with the pediatrician and all based, considering my deficiencies or regular routines, vaccinations and all. These days, I'm not blaming on any parent, but it's just that they are going on their self decisions of giving the supplements or whatever it is. So, how far is it right?
I don't think it's right to be giving medical supplements without appropriately measuring the levels or without expert advice. Part of the problem is also the fact that the pace of life is hectic. Sometimes it's very difficult that people may not want to negotiate to traffic. But here's the benefit. In our country, we have access to experts easily. Unlike a lot of countries in India, the benefit is that you can access a specialist very easily. And medical services have become widespread. So it is important to seek a expert review before you take up any medical supplements. I find that a lot of youngsters, especially in the teenage years to early 20s and those going to the gym, supplement, there's this rush to build Arnold Schwarzenegger like muscles and
Yeah.
they're
And the
all
packs,
using
fancy six packs.
absolutely, and they're all using such heavy amount of whey protein and all these supplements, and you find that they all walk into our OPD very often with joint pain and they may have elevated uric acid. Similarly, they may have injuries because of overuse. So it's good to seek expert opinion. Vitamin D. Now, earlier we saw vitamin D deficiencies, but of late we are also seeing people with toxic levels of vitamin D,
Yeah.
more than 100.
Because not just in the children, even the teenagers or youngsters or middle-aged people also, even if they're down with a little backache or leg pain or whatever it is, if they're having any brittle nails or like hair fall, whatever it is, they just come down to their conclusion, go for a chat GPT consultation and end up with
It's
self-medication.
still artificial. I think you still natural human intelligence must
Yeah.
score over artificial intelligence. So I think
I wish
if you
everyone gets onto that line
yeah,
of
me too.
awareness.
Me too. I think it's so important. There's also something you were mentioning about neck and back pain.
Yeah.
There's also something very important called as ergonomics. And a lot of what we see today is related to poor posture. It could be due to repetitive motion injuries, texting, holding the phone. It puts so much pressure not just on the wrist but also on your neck and upper back. Similarly, how you sit, how you look at the screens, your chair is all part of ergonomics, and it affects people at every age and at every level.
And the amount of time as well.
Yes, absolutely.
Sticking to one posture for long durations.
So it's important that everybody recognizes ergonomics and how to deal with it. People must get up and walk. So I tell people often that have a comfortable chair, sit at about 90 degrees or just a little bit leaning back. Make sure that your screens are at eye level, and make sure that every half an hour, 45 minutes, you get up and walk. Don't sit for long periods, along with maintaining good muscle tone, and you'll find that things rarely go wrong.
So when it comes to this knee pain in youngsters, especially the one who gets to work on the desk for longer duration, they just go for knee bands or whatever comfortable stuff it is. They go with it and then they come down to a conclusion that okay, it's just because of sitting at one position for longer time, so I'll just take a painkiller, stick with this knee band and then sort it. How far is it right?
I think it needs to be approached a little bit in detail. So, first of all, if you have knee soreness or knee pain, and that is consistent, you need to see whether your vitamin D is okay. You need to see whether you're consuming too much of protein. Or sometimes these days we tend to see that people go on binges of eating and drinking. So
Yeah.
has that happened recently? Also, is your chair comfortable? Are you sitting cramped? These are small, easy things. Chondromalacia is very common and commonly called as runner's knee. So chondromalacia patellae, typically you have pain because you have been sitting for long periods, like I said, the cinema sign. So chondromalacia can be because of multiple factors: low vitamin D, putting abnormal stresses, or perhaps not getting adequate activity. So if you feel that it is chronic, then you should seek attention. These things can be easily cured, right from increasing your muscle strength, taking appropriate supplements, to sometimes perhaps needing injections. All things can be dealt with when you see people. If you don't see people, what happens? The right people. That's the next thing I want to talk about. So let's say that you have persistent knee pain. It could be that the kneecap or the muscle, so the kneecap is held in position by a number of muscles and ligaments. So like if you are one side of is strong and one is not, then the kneecap may be being pulled to the side. What is commonly called as lateral tracking, and that can be corrected so simply that when it is identified clinically and through an X-ray, we may send the patient for simple vastus medialis obliquus. This is the inner muscle. It is the first to appear in the womb and also the first to become weaker later in adult life. So as we exercise, as we stress some muscle groups, some become stronger, some become weaker. So if the inside becomes weaker, then the kneecap will move to the side, much like a horse. So if you have the horse with reins, if you pull it to one side, it will go to one side. So very commonly in the knee, if that is being pulled to one side, the kneecap goes to one side and it tracks abnormality.
It starts drifting.
That's it. And then when it becomes moving abnormally, moving to one side, then the back of the knee wears abnormally. And that's where you start to develop these changes. So when you identify it early, simply put, not by putting just your band, but by seeking help and advice, it can be corrected without deteriorating. So if you have persistent pain, swelling, you feel most of our knees click. I'm sure everybody is aware. I'm sure you know that we have air in our joints. So like cracking the knuckles, very often when you suddenly bend, you may hear a crackle. That's not abnormal. Or you may hear a click. But when that is persistent, painful, causes swelling, then you need to seek advice.
So let's put these youngsters aside for a while. Coming to the middle-aged and above middle-aged people.
Yes.
Irrespective of going through all sorts of discomfort, pain and everything, they tend to have that fear of knee replacement surgeries comparing to the old procedures, old traditional orthopedic surgeries. So your advice to that that adults who are worried about the knee replacements, the pain, the long procedures and all?
So it's a lovely question. I'll tell you a little story. Few years back, my mother-in-law was facing a lot of knee problem in her early 70s. And it came to a point that, she couldn't drive for long distances. Her daily activities and chores were restricted. And I said, you need to have a replacement. But that's the point, this fear that is there. And because of that fear, she kept deferring it to a point where her mobility was restricted and she came onto a wheelchair.
Oh my God.
And at that point in time, she said, no, I would like to regain my quality of life. I want to drive, enjoy my life. And I replaced her knees and she regained her quality of life. 2 months after surgery, she was driving happily. We replaced both the knees in a go and she was very happy.
That's quite a
But
motivating.
one night before the knee replacement, she not only did she have some apprehension, so did my wife, although I was doing the surgery. It is but natural for anybody to have apprehension. I would be apprehensive about any procedure on myself as well.
That's quite natural.
It is, isn't it? That's human nature. That's why you have to go with people or choose people you know and trust and who have a good record. It's very, very important. As we discussed, all over the world, knee replacements done well are some of the most successful surgeries in the history of mankind. No other surgeries have been so successful as hip and knee replacements. And today, given all the backup we have, and we never operate on anybody until we have analyzed them both medically, anesthetically, and they have been made fit. This is not a surgery where we would risk a person's life. So they are extremely successful. People's whole quality of life changes, and today we adopt measures to make them risk-free, to promote early recovery, to promote accuracy, patient satisfaction, and that's how they do well. So it's important not just for the patient to connect with the doctor, but it's also important for the doctor to connect and communicate with the patient. I think that's what makes the difference.
I might sound a bit cheesy or filmy, but still, having life back from wheelchair to regular routines and then living a normal life, it just feels like a rebirth if I'm not wrong.
Well, I think, most people who have a replacement, so we see a standard pattern. A couple of weeks after surgery, they say, yes, I think, yeah, it feels sore, but I'm happy. But give them a couple of months and all of them come back and say, I'm so glad we had this done.
Yeah, that's what feels like a rebirth again.
Yeah, absolutely. I think mobility is life. I think if
Yeah.
you don't walk, don't carry out your activities, and you restrict yourself,
Yeah, that's very depressing, like sticking to one place and relying on someone else for everything, being a burden to someone. That psychological pain, that mental pain is like very heavy compared to the physical pain, is what I feel.
it's not that painful, madam. You'll be surprised to know that after surgery and
I'm
replacements,
so sorry. I was talking about the before surgery pain.
yeah, even the before surgery pain,
Okay.
I often tell people that once you have surgery, not only will you look after yourself, but you look after them as well, the others as well. And that's what they all say after 2 months. Yes, we are able to take care of everybody. So pain before surgery is something, and stiffness, that if it is very intense, it's impacting your quality of life, then yeah, I don't think one should suffer or struggle with that.
So when it comes to appreciate the part of advancements in orthopedic surgery compared to the traditional orthopedic surgeries which were done quite some time back, I would like to know the involvement of robotics into this recent advancements.
Right. So robotics is something in which what we have been finding. So as the effort has been with knee replacements to increase the whole effort, or the whole objective is two things. One, to increase patient satisfaction, because what we have found is that no matter how well done, a small percentage of patients always experience a little bit of dissatisfaction after surgery. And the whole effort has been to bring that down into a very minimal, which has been extremely successful. The other effort has been to increase the lifespan of a replacement, pretty much because as we were discussing, that you have younger patients getting operated. So to that end, today technology is playing a great part, and not just in the way that we design implants, and we are using modern implants that are portrayed to last a bit longer, especially in younger patients, but we are focusing on trying to improve the accuracy of implant positioning. So the traditional method was, when you were doing surgery, you would position the implant on a given system that is common for most people. However, we know that God hasn't made us all the same.
Yeah.
Our 5 fingers are not the same.
The same.
Similarly, every patient has a slight difference in their anatomy. So to see that, initially came, what we called it CAS, computer-assisted surgeries, where we would get the data. Sometimes you would get a CT before surgery, a pre-plan. But today, we can do everything through the technology of robotics. And our robot is driven through artificial intelligence. So we are quite focused on that. So how does that help? The main benefit, in my experience and opinion, about robotics is the data collection. Imagine the vast volume of data that is coming through, because each time we do a knee replacement using robotics, we are analyzing the data. We are looking at your individual anthropometry, your measurements. And
Considering one patient, all the pros and cons
yes,
in it.
how much variations there are. And then when we perform the surgery, after those measurements, the attempt is to make the implant sit the best as per your measurements with minimal discomfort. So robotics, very often minimal releases are involved. Have we found any difference at the minute? Well, the major difference is that you get much more data. It is how you position the implant using that data. And in the longer term, so as joint registry data has come in and as data comes in the longer term, we will get to know whether it is helping implants last longer. Certainly, the effort is to have increased patient satisfaction using that data.
So, considering your daily routine IP and OP, so what's the most common age group you get to see with this knee issues?
Okay, so in India, we tend to see people about a decade earlier than the West with knee arthritis. So very often, like I was telling you, about 40% of the people that I see over the age of 40, sometimes even if they have minimal symptoms, they may have some minimal changes, degenerative changes. It accelerates with women between 50 and 60 and men between 60 and 70. So that is the age group that we are tending to see with a little more pain and arthritis that may require intervention.
So, it varies based on the gender.
Oh yes, absolutely. Women we tend to see a bit earlier. Also, we tend to see people who've possibly had previous arthritis, previous injuries, or people who've had, a familial history. They may come in a bit earlier.
So, considering the availability and affordability of the implant, what do you suggest the patient? On what grounds you classify?
So, when I look at a patient, obviously the attempt for younger people would be to save the joint. And barring very, very severe cases, for most people, we successfully save the joint. For older people, unless the arthritis is very severe and impacting their quality of life, we rarely recommend a knee replacement outright. Usually, we will look at other surgical or non-surgical measures. We may look at measures to increase the joint lubrication, muscle strength, correct any footwear. All these things are usually taken. However, when people have very, very severe arthritis and nothing else is working, it is only in them that we would consider a replacement. And that's when we suggest that you may require a surgical procedure.
So, when it comes to the footwear, as a woman, I'm pretty curious to know about this because many women they just love to go for pointed heels, high heels, wedges, whatnot. So, will that have any direct impact on this knee injuries?
So
I mean-
before so when you look at it, a lot of the earlier philosophy was that if you wear high heels, etc., it's the spine that gets loaded. But along with the spine, people forget that the knee is in the way. So yes, if you're changing the way your footwear is, so normally I recommend footwear that's not completely flat. We would recommend footwear with a small heel. We would recommend footwear where there's a small curve, what is called as the arch on the inside. And for most people, that is the normal footwear that they wear. However, when you have arthritis, then the shape of your knee changes and that may impact the change in your foot as well. Sometimes the foot becomes flat, goes towards the outside, sometimes, so there's a compensatory effect. That's why when we look at people who have got arthritis, we also look at their feet. And if it's not somebody who requires surgery outright, then usually we also recommend correcting the footwear. Today you have advanced technology like foot mapping.
Yeah.
They will look to see how you,
Customized
that's
footwear.
right. So, very often we have these lateral wedge insoles where the outside of the foot is raised. So that puts less weight on your knee on the inside. So there's lots of measures that come into force. You also have to accommodate, for example, very often people may have pain behind the heel. Either, it's called as Achilles tendinitis and diabetics more so. So for them, we may actually recommend a heel raise to put less stress. Similarly, some people, especially diabetics in whom it's very common, they'll tell you that when I get up in the morning, the moment I put my foot down, you get pain below the heel. And that's called plantar fasciitis, and that's very, very common. And for those people, we recommend a support under the heel, under the, it's called as a heel cushion. So, yes, there are so many different types of footwear supports, heel raises, lowering. That's why one size doesn't fit all, and you need to see what you're dealing with.
So when it comes to flat feet condition, what are the possible complications to look for?
So flat feet most commonly. So we tend to see children coming into our OPD. The parents are actually more anxious than the children, and they come in and say, "My child is 4 years old, doctor, but the foot is flat." So that's not a true flat foot. That's a physiological flat foot. And most children, if you give them good shoes with an arch, will grow out of it. Who are the people to look out for? So there is a condition called as an accessory navicular where one of the bones in the foot has a protuberance, and that can cause a rigid sort of a flat foot where it doesn't form. So what do we look for? We look to see that are you an older age group in which you have lots of foot pain, in whom the arch is not there, the back of the heel is going towards the outside, what is called as a hindfoot valgus. And if you stand on your toes, if the arch is not reforming, it's called as a rigid flat foot. So there are conditions that cause it. For example, if the bones of the feet are fused either through birth or after an injury, those are people who may have a rigid flat foot. But for most people, a flat foot can easily be dealt with by exercises and wearing a medial wedge sort of a thing in the foot.
As we have a situation talking about flat foot in children and the apprehensive parents about that condition. So earlier there were days wherein like newborn babies were given like a typical oil massages, and then like only sagging their hands and legs, assuming that that will help them grow better in height, length, or whatever it is. And these days the young parents are about very delicate baby baths and all. So your views on
I
this?
don't think, if you look at it, keeping the traditional massages was a way to keep the joints and muscles supple. Um, it's all right, but there's very little scientific evidence behind it that it would lead to better growth or to anything. I don't think there's anything wrong with it, but I don't think it's going to help you in any way.
But currently, the young parents are like, oh my god, don't rub too hard, don't pull too hard. I mean, they're like very gentle with the baby.
I
So,
think babies are fragile and one should be gentle. But the old days and giving the massage, when they used to do it, nothing used to go wrong either. So, a good massage improves the circulation, helps the joints become supple, keeps moving them. There's nothing wrong with doing it gently.
so when it comes to the massages, moving from newborn babies to the young people or middle-aged people, they get the massages, neck cracking, elbow cracking at massage centers or haircut centers by unprofessionals. And there are certain incidents wherein one person, he just passed out in the moment while he was getting his neck cracking done. So
I'll tell you another story with this neck cracking. So there was a person I know who went to a barber and told him to move it and shake it and jerk it because he used to do it for him always. But that particular time, his neck got stuck and he had a neck bent to the side, what is called as a torticollis, because one of the facet joints, it just got stuck. So these are things that one shouldn't carry out except by trained professionals. And it's all very nice to have a massage so long as it doesn't hurt you. Now the only benefit of massages is that it makes you feel good. Now, scientifically, except for that, we don't feel, if you've got paralysis, if you're not able to move your joints and muscles yourself, then it's important that, like we discussed, I was telling you, and it keeps your joints supple, helps with movement, prevents the atrophy. That's good. However, for most people, trying to do these abnormal maneuvers can end up being very dangerous.
So, moving on to again the management of knee replacements
Yeah.
and all. Apart from the surgical procedures, talking about all the possible non surgical, minimally invasive procedures,
Yes.
how does a stem cell play a role in this?
Um, it's a great question, and I know that it's a very very contentious. You've said the cat amongst the pigeons, and certainly that is a you know. So I'm not against it. I practice it, but not for everybody.
Certain limitations are
That's right. So where do we use it, and how do we use it? So like I said, we've had a extremely good experience with chondromalacia, the runner's knee, where you get knee pain in younger people, where we tend to inject these highly concentrated growth factors from your own blood. Normal PRP is about 4 times, but the one that we tend to use has about 12 times concentration. And we have been using it now for some time, and we find that given to the right individuals, it's very useful. I don't recommend it for older people.
Okay.
Why? Now, when you're about 50, 55 or older, how much regenerative potential do you think is there for that? Your own cartilage or through your own blood. What is arthritis? Why does it happen? So basically the fundamental, you have to go to that. Arthritis happens because the wear and tear is greater than the repair.
Yeah.
So for most of us, or for people younger, why is it that they don't have arthritis? Because if they have some damage to the joint, either through wear and tear daily or an injury, it repairs himself. But as you grow older, like you age, so does your cartilage. And when that wear and tear is worse than the repair, that's when your cartilage starts to break down. So how much repair potential would an older person have? And that's exactly why we don't tend to use it for older people. So what is my approach for arthritis or changes? So younger people with severe chondromalacia, not requiring any surgical intervention, I do tend to advocate using highly concentrated this injection. If there is a focal cartilage defect, for example, very often people come to me that they've had an injury, they're getting persistent knee swelling. One of the signs of a cartilage deficit knee is if you get a lot of swelling in the joint. And we usually pick that up on a good MRI. And in these people, depending on the size of the cartilage defect, we repair it quite successfully. So you have procedures using a camera where you can take the patient's own cartilage, mix it with their blood and paste it back. Or for larger defects, we can then use a two-stage procedure where we take their cartilage from a non-affected part, send it off to the lab to grow it, and about 4 weeks later, if it's a very large defect, we tend to paste it back. And we are always very careful to see that the axis of the knee is not disturbed, because if your knee is crooked, even if you do these, it will still fail. So if your knee is crooked, it has to be corrected. But other than that, these are very good procedures. Sometimes we also take the bone marrow and spin it in a centrifuge and then paste it back. So different sizes of different lesions, we find that if there is no big deficit, but there is a generalized wear, using this regenerative principles of your own blood, or if there is a cartilage deficit, then depending on the size of the deficit, we either do use BMAC or AutoCart or we tend to use ACI. What about older people? So the strategy for older people is completely different. So let's say you're in your 50s and the knee has not completely broken down. You have joint space. However, you're getting pain. In those people, a very good strategy is to give hyaluronic acid injections, what we commonly call viscosupplementation. And those injections we now combine with these mesenchymal cells, not from the patient but a pooled donor. So these are now commercially available. So giving that in people is very effective provided the joint has not completely broken down. So
Okay.
these are the way how cell therapy can be used well and works well.
So, are there any limitations on the frequency and duration of the cell therapy?
So if you have very large defects, then you have to be careful because cell therapy may not work. Much older people, like we were discussing, they don't have much regenerative potential in their, with aging. So in them it will not be successful. Similarly, if you have a deformity, so why did your cartilage break down? So if you have a varus or valgus deformity, the joint is being loaded abnormally at a point. And if you don't correct that, even if you use the cell therapy principle, it is still going to break down again, which is why one size does not fit all and it needs to be tailored.
So, let's say if you are going for this particular cell therapy in older people, maybe 50 plus or so, who are already down with diabetes since quite a while. So, are there any?
So we very rarely go for cell therapy in older people. I can perhaps very single digits in the last decades. We don't usually, unless there's a focal cartilage defect, and then we tend to use BMAC. Most people, and if they have chronic comorbidities, unless they're well controlled and in an older age group, I wouldn't recommend cell therapy.
If that's the case these days, even the young adults, even the children are diabetic, the teens are diabetic. So, considering that conditions, let's say in people who are around 20 to 30 or 30 to 40, and they are properly diabetic,
Yeah.
and they're on, let's say, on insulin or other medication or something, and then how it would be the response for this cell therapy in them?
So I don't think it is a contraindication in younger patients, provided they are well controlled. You see, if your sugar is not well controlled, it will make the joint painful anyway. So usually we control their diabetes well, but diabetes itself is not a contraindication for cartilage restoration or regeneration in a younger person. Now, do they have other metabolic problems? That could vary. So if you have got other
Like?
metabolic or problems which are, or if you are suffering from cancer, then we may not choose cell therapy.
Okay. So, any other conditions to be contraindicated?
Oh yeah,
irrespective of
I
cancer?
wouldn't do cell therapy or regeneration in a cancer patient at all. I don't think that's recommended or advocated.
Any other conditions
yeah,
beyond cancer?
yes. So there are people who have got genetic defects or genetic issues in whom you would have weakness of the cartilage. Those are people in whom we wouldn't do it.
So, worst complications to be noticed when there is rejection of cell therapy?
You will have pain again, the defect will not heal, you will have swelling, and it would be an exercise in futility. Rarely, if poorly controlled diabetic, then you can also end up with joint sepsis. But the overall chances of all that happening are low. The bigger problem is if the injections are not placed accurately or by people who are not experts, and let's say it goes into the tissue and not the joint, then it can form a collection of blood, a hematoma, or it can cause a focus of infection, and that's more important.
So, after the cell therapy, are there any first line measures to be considered for the next 3 months or 6 months?
No, you can have your normal life as you do. It's important to keep things like your sugar, uric acid in check. It's important while you're undergoing cell therapy not to carry out too much of impact activities or disrupt the healing process. Additionally, things like steroids, all these should be avoided. As far as we are concerned, Steroids are a big no-no.
So, if you have to give a wise advice from your side to the young individuals considering this joint issues, what would it be?
I would suggest keep moving, start early, play sport, warm up, cool down, nutrition, hydration, and avoid junk food. Keep your
Nutrition
weight
with the
under
proper
control.
monitoring,
Absolutely, with proper monitoring.
not through commercials.
No, not based through anecdotal evidence, through proper scientific evidence.
Very
Great.
happy. It's a great pleasure.
Thank you so much. Thank you for being here, and very grateful that you've come.
Thank you, Dr. Aditya.
Thank you very much, ma'am.